Good evening, everyone. How are you all? So, welcome to First Aid AMC Clinical free 2-week session. And this is your last session as part of the free 2 weeks. And I hope you guys have been enjoying our session so far. So, for the last 2 weeks, we have done a lot of classes, and I tried my best to give you a bit of a test of how the course classes is going to look like. And you got to know about our theory classes. You also got to know about our other mentors who takes those kind of role play sessions. And you also understood how to do role play, right? That's the basic thing. You have a bit of an idea about psychiatry because we did a psychiatry mental status exam class followed by a role play on that. And then we have been doing some medicine clusters so far. So we have done cardiology, chest pain cluster. Last class we finished syncope cluster. And you know that how we are trying our best to make sure that multiple cages are clustered into a similar format so that you don't need to remember everything. We just make sure that at least 6 to 7 cages are coming into one cluster. You already will know how to take a history of that cluster, how to do physical examination of that cluster. All you need to know how to come to the diagnosis and how you're going to manage that patient. That's all that you really need to remember. So I hope this cluster-wide approach is making sense. I hope you are enjoying these sessions. But this is our last session for your free classes. After that, we are going to start the course in full rhythm. I have already posted in the course group that your orientation class for the new batch is going to be on 23rd, which means just in 2 days on Friday, we'll do that orientation class. And after that, we will start the course in full rhythm. Okay? So if any of you still haven't joined the course and you are willing to join, definitely you should start the process and join the orientation class because orientation class is going to help you to understand the course much better. We will discuss how to take most out of this course, how to start your preparation, and what's really, really important for exam. So that's going to be a very important session to attend. Okay? You might have also noticed that there is a free session coming up on 30th of January, and we're going to discuss about the registration pathway, career guidelines. So definitely worth joining that class as well, because I know you have a lot of questions about job, after registration, lots of complicated things are there to learn. So I will discuss in detail about that pathway as well. Okay. So have you guys started your preparation? Like you have started doing those cluster that we have done? You guys can hear me, right? Yeah. Okay, brilliant. So let's continue with our tonight's cluster. Tonight we have two cluster to finish. First one is palpitation cluster, and the second one we'll do hypertension cluster. Both of them are very important for exam. So let's talk about palpitation or nervousness cluster. Usually it comes under palpitation, but sometimes we can also do the nervousness cluster under the same format. So these are the differential diagnoses for palpitations. If a patient comes to us with palpitation, These are the differential that we need to remember. We have cardiovascular. In cardiovascular, it could be ischemic heart disease, myocardial infarction, hypertension, arrhythmia, any valvular heart disease, and heart failure. As part of CNS, it could be a stroke, TIA, epilepsy, infection, or head injury. Same. Usually CNS, this differential will be same everywhere. And then we have endocrine electrolyte. For endocrine, hyperthyroid is very important for exam. Hypoglycemia can come as palpitation or nervousness, and then pheochromocytoma. Electrolyte imbalance such as hypokalemia, hypomagnesemia, they can also cause palpitation. Respiratory related, we know pulmonary embolism can cause palpitation and respiratory failure can do the same. Anemia can be a cause, anxiety, very important to rule out, like panic attack or any stress disorder. If it is a female patient, then especially after 40, we should also think of menopause because menopause can come as palpitation and nervousness both. There are some medication which can cause palpitation. Very common is salbutamol, which is the inhaler you use for asthma or COPD. And then there is excess tea, coffee, or recreational drugs. They can also cause the same. Drug withdrawal, like if a patient is alcoholic and then suddenly stop drinking alcohol, as an alcohol withdrawal, the patient can also have palpitation. So under recreational drugs, we will also think of any withdrawal of any of these drugs as well. So you can see there is a lot of differential diagnosis to consider when there is palpitation. Now, easy way to remember is you can see there is 2C, severe CNS, 2E, endocrine electrolyte, 2A, anemia, anxiety, 2M. Actually, it's 3A, right? So endocrine electrolyte and excess tea, coffee. 2A, anemia, anxiety, 2M, medication, menopause. Okay? And then there is just 1R, respiratory. So I usually remember by Macer. So Macer is a mnemonic for all the differential diagnosis for palpitation. Now, it's not also difficult to remember 2C, 3E, 2A, 2M. Sometimes that's also easy to remember, okay? So if you just make it easy, you can just write it like 2C, 2E, 2A, 2M. And then you can easily remember the excess tea, coffee. It's pretty easy to remember. And then there is respiratory. Even if you do in this way, respiratory and recreational drugs, then you can easily remember these two as well. So whatever makes it easy for you, there is no hard and fast rule. But sometimes even like to me, it's easy to remember by 2C, 2A, 2E, 2A, MR. But sometimes if you don't want to do that, you can just remember by MESA. So whatever works for you. So these are some of the drugs that causes palpitation. So you can see there's a whole lot of medication. The common one that we use is definitely alcohol, alendronate, that's a osteoporosis medication, amphetamine, which is an illicit drug, antipsychotic, antiarrhythmic, antidepressant, caffeine, cocaine, digoxin, any diuretics. So there are a lot of medication which can cause palpitation. Okay, taking the history of a patient who comes to us as palpitation. So first of all, palpitation patient comes acutely. So you will introduce yourself with the patient, reassure the patient, and make sure patient is vitally stable. So now that we have done two classes on cardiology, right now you should know how to take these initial bits, right? You know how to start the case. So you know how to approach. Now in the hemodynamic stability, it's very important that you ask blood pressure, pulse, rate, and rhythm, because this could be a case of atrial fibrillation And in that atrial fibrillation, pulse will be irregular. So you can start in this way. Hi, John. This is Dr. Arshan. Very nice to meet you. John, I can understand you're having palpitation for the last 2 hours. How are you feeling now? So patients say, I still feel my heart is jumping. I'm so sorry to hear that, John, but now that you're here, I'll try my best to manage your condition. Before I ask you any questions, please allow me to talk to my examiner. I'll make sure you're vitally stable to answer my questions. So then you turn towards the examiner and ask about the vital question. After that, you come back to the patient and you ask the open-ended question, which is the presenting complaint. In here, it is palpitation. So John, could you please tell me a little bit more about this jumping of your heart or thumping of your heart? There are several ways patient can say this: jumping, thumping, palpitation, racing of the heart, everything is same. So patient will give you a bit of an idea, but we need to know all of this from the patient. We need to know when did it start. So if we already know that palpitation has been happening for the last 2 hours, do we again ask it? No. Okay, so do not repeat question. We need to know what were you doing? When did it start? When it started? Did it start suddenly, gradually? Is it for the first time? Many times patient will say, no, it happened before. In that case, you need to ask the detail of the previous episodes. So how many episodes so far? When was the first one? Can you describe what you were doing in these episodes? How long do they last? How do they stop? Spontaneously, or do you need to do something to make it stop? What have you done so far regarding this? Is there anything that makes it better? Anything that makes it worse? That's the detailed question about the palpitation. A lot of notes, they will ask you that, can you show on the table how the palpitation feels like? We don't really need to ask the patient to do that. Okay, so that's just an annoying thing to ask. So no need to ask the patient to show it on the, or tap it on the table to show how the racing of the heart is looking like. So just ask this question. When did it start? Did it start suddenly or gradually? What were you doing at the time? Is it for the first time? If not, ask about the previous episodes and then finish with anything makes it better or worse. So after the palpitation, we go to the associated symptom. So along with the palpitation, do you feel dizzy or lightheaded? It's very common for a patient who has palpitation to feel lightheaded or dizzy during those episodes. So ask this question, and then you go to the differential diagnosis. So for CVS, any chest pain, shortness of breath, any nausea, vomiting, excessive sweating, any relationship with exercise or exertion, any swelling of your feet. So chest pain, shortness of breath, we know for ischemic heart disease. Same nausea, vomiting, excessive sweating for similar MI or IST. Any relationship with exertion or exercise, that's also suggests this is related to cardiovascular problem. And swelling of your feet or ankle, that's for heart failure. So all of these are differential diagnosis anyway. Then we go to the CNS. Any headache, any problem with your vision or speech, any weakness or loss of consciousness. That covers most of the thing. Now, if we want, we can definitely add a bit more question like any recent head injury, any jerking movement of the body, or any history of seizure or convulsion. So these are not must to ask, but if you have time, you can definitely ask it. So CNS is not our most important differential diagnosis for palpitation because it's not very common for this condition to present as palpitation. They have lots of other presentation. But still we ask it because nervousness is one of the nervousness is, this cluster is also about nervousness. So in a patient who has CNS related condition, they will present as more nervous and anxious instead of having palpitation. But I would suggest that you keep the CNS as a differential diagnosis for both palpitation or nervousness cluster. But very quickly, our focus is mainly cardiovascular and endocrine. That's two is our main focus. So for endocrine, we have hyperthyroidism, any recent change in your weather preference, any change in your bowel habit or body weight. So for thyroid, we know that hyperthyroid patient, they feel excessively hot and sweaty all the time. Even if it's winter, they will feel excessively hot. So that's why we ask, do you have any change in your weather preference? They will say that they don't like hot or the sunny weather. Any change in bowel habit, so they get diarrhea and they also lose body weight. For pheochromocytoma, any episodes of headache, sweating, or flushing of the face. So pheochromocytoma is a tumor of the adrenal medulla or medulla of the adrenal gland, and they have these episodes or paroxysm of headache, sweating, pallor, palpitation, headache, flushing of the face, and they get hypertension. So they get it as episodic. Then we have hypoglycemia. For hypoglycemia, we know that patient usually to have hypoglycemia, we ask, does it happen when you skip your meal and then do something very exertional? So patient skipped their meal and then went for a massive hiking, maybe mountain trekking. So then they can definitely end up getting a bit of a hypo attack. So we should always ask that does it happen when you skip your meal? Any history of high blood sugar? So that finish our endocrine causes. Next, anemia. So do you feel tired or fatigued these days? Infection. If a patient currently have any infection, that can also cause palpitation. So do you have any fever, runny nose, any cough, any flu-like symptom? Respiratory, any recent long distance travel, any past or family history of clot in your legs or lungs. That's for pulmonary embolism. For electrolyte imbalance, any recent diarrhea or vomiting. Okay. And then we ask about SADMA. So do you smoke or drink alcohol? Do you take any regular medication? Any recreational drugs? We also ask, have you been using any nasal decongestant or inhalers? So there are nasal decongestant which can cause palpitation, and then inhalers like salbutamol that can also cause the same. So very commonly it can be the cause of palpitation. And also do not forget to ask, do you drink excess tea, coffee, or soft drinks? Do you take any of the social drugs such as cocaine, marijuana, or ecstasy? So these are very common. Even there is a case in exam where the cause of palpitation is excess coffee. Australians love coffee. If you walk in the morning, especially during the office hours, you will see almost everyone have a coffee in their hand. And they love to have coffee like I would say 4 to 6 times a day. Now, ideally, 2 cups of coffee is okay. And they take very strong coffee, not like coffee like normally you would take. Okay. So, but if you're taking 4 to 6 cups of coffee, that can definitely cause palpitation. Past medical history, so any other medical condition such as high blood sugar, high blood pressure, any heart disease, or any history of rheumatic fever when you were a kid. Why we're asking rheumatic fever? Rheumatic fever can cause rheumatic heart disease, and that patient can also have a bit of a heart-related complications, and they can present with palpitation. Any family history of sudden death due to any heart condition. So sudden cardiac death is important to rule out. Ask about social history. So who do you live with? Is there any stress at your home? Do you work? Any stress at your work? Are you generally an anxious person? Do you worry a lot about most of the trivial things? There is a condition called generalized anxiety disorder. That patient usually are always anxious, always thinks about something bad is going to happen, and they worry about everything. So that's generalized anxiety disorder. Patient can have palpitation in that case. And if it is a case of panic attack patient will come to you with episodes of intense anxiety where they feel their heart is racing, so palpitation, they are trembling, shaking, they get sweaty, they feel that they're going to die. Okay, so that's panic attack that can also happen, and patient can come as palpitation in that case. So when you ask the social history about the stress, if you find any stress, then you will think that, well, is this patient actually having a panic attack? And that's why this palpitation is happening. But without any stress, without any problem in mental health, very unlikely to have a panic attack. So we don't need to ask panic attack question in that case. If it is a female, especially after 40, we will also ask about menopause. So we will ask that when, let's say it's a patient who is 45-year-old female. So we'll say that when was your last menstrual period? If patients say that I haven't got any period for the last 1 year, then you will say, well, have you got any symptoms such as, so what are the menopausal symptoms such as any hot flush, any night sweats, any frequent mood swings? Okay. So hot flush, night sweats, mood swings, lots of others are there. So they can also have issue with bowel bladder. They can also have muscle aches and pains. They can feel very irritable all the time. So these are the common features of menopause. Few symptoms, if you ask, especially hot flush is the most important question. So then you ask, are you experiencing any hot flush, night sweats, frequent mood swings? That would be enough for ruling out menopausal symptom. So this will be your history for palpitation cluster. So again, to start with the palpitation history, make sure patient is vitally stable. Ask about the palpitation question in detail, associated dizziness, lightheadedness. Then you go to the differential diagnosis, CVS, CNS. Then you go to the endocrine causes, hyperthyroid, pheochromocytoma, and hypoglycemia. Then you just rule out all the other necessary differentials such as anemia, infection, respiratory related, especially PE, electrolyte imbalance, SADMA. In the SADMA, very important, ask about any medication patient is taking, any nasal decongestant inhaler. Do not forget about this bit, tea, coffee, social drugs, and past medical history, sudden cardiac death, and finish with psychological question like social history to rule out any stress. Okay? Clear everyone about the history? Perfect. Going to the physical examination from examiner. So first of all, we will start with general appearance. So on general appearance, is my patient restless or comfortable? Now in here, restlessness can be a feature of hyperthyroidism. So it's very important. Is my patient dressed appropriate to the weather? A patient who has hyperthyroidism, they will not wear a lot of clothing, even if it is a winter, because they're always hot inside. Then, as part of pickled, ask about any pallor, any edema, or even you can ask about dehydration. Ask the vitals and BMI. BMI is important because one, that it's cardiovascular system. Obesity is a risk factor for cardiovascular complication. And the second is if it is a hyperthyroid patient, their BMI can be quite low. Next, start checking the neck for any raised JVP or carotid bruit, and then do the full cardiovascular as we have been doing so far. Same thing. Say that you will do the full central nervous system, including cranial nerves. And also, we will do thyroid examination. So you will say, I would also like to check the thyroid gland for any palpable thyroid lump, any eye sign of thyroid disease, or any sign of thyroid eye disease. Because the most common cause of hyperthyroidism is Graves' disease. And Graves' disease has Graves' ophthalmopathy, and lots of eye issue is there, like lid lag, lid retraction, exophthalmos. So those sometimes we can find. And then on respiratory system, just ask, is there bilateral equal air entry? Any bibasilar crepitation. Why bibasilar crepitation? For CCF. And finish with office test, urine dipstick to rule out any infection, BSL for hypoglycemia or diabetes, ECG, definitely, because this is a palpitation case, we want to rule out arrhythmia. Okay, so office test, we will ask about urine dipstick, BSL, which is blood sugar, and ECG. So that's going to be our physical exam from examiner. Now we are going into the cases under this cluster. So there are mainly two important cases in here. One is SVT and another is atrial fibrillation and flutter. So starting with SVT, you are a junior HMO in emergency department. A man came in with thumping or racing heart and giddiness started today. Take history from the patient, physical exam from examiner, ask for investigation from examiner and explain to the examiner, and explain diagnosis differential to the patient. This is how the task is actually in exam. So they will always say where history from the patient, physical exam from examiner, ask investigation from examiner and explain to examiner, and diagnosis differential to the patient. So you should always know that which task is going to be with patient and which task is from examiner. So in this case, you will follow the same history format and you will find out patient have been having this palpitation and giddiness since 2 hours, associated shortness of breath. Previously, 3 episodes, all of them started suddenly, lasted 2 hours, and then it stopped all of a sudden. He also takes 6 to 8 cups of coffee a day. No smoking alcohol, no family history. Patient is a bit anxious and has some stress. So sometimes in a same question, you can get multiple issues. So do not just assume that there is only one thing in a case. A patient can have SVT, but can also have a stress disorder. Okay? Have a look on this ECG. Did any of you check the ECG video that I have uploaded in your student portal? If you haven't, then please make sure to go through that ECG class for a bit of a basic, because you need to have that basic for even clinical exam. So after your history physical examination from examiner, your third task is ask investigation from examiner. So you will ask for ECG, and then you'll be given this ECG, and then you need to explain this ECG to the examiner. So we know that this is a palpitation case. So where we are going to look first, we will look at the long lead. Long lead is the lead 2, where we can see the full length of the ECG. So if we look over here, first, is it regular or irregular? It looks regular, right? Because all RR interval is same. So it's regular, so we can take the rate. What's the rate looks like in this patient? So there is one large square and just a little bit of one small square, right? So this is close to 300. So even if you say, let's say 280, that will be better. Or even if you say almost 300, that's also fine. So now you know how to check the rate and rhythm. After that, we check the P wave. So if we look here, so this is our QRS complex. The wave that follows the QRS complex is the T wave. Okay, so after this QRS complex, the wave that follows is T wave. So there is no P wave in here. That's really important to differentiate sinus tachycardia from SVT. Sinus tachycardia, heart rate will be elevated, but there will be P wave. But in case of SVT, there is no P wave. So P wave is absent. That's the most important thing because the case can come as simple sinus tachycardia as well. So if you look over here, T wave is there. There is no P wave, but then there is QRS complex. So the QRS is very narrow, right? Like we know that normally QRS complex is between 1 to 3 small square, but this is not even 1. It's just like very marginal. So it's very narrow QRS. And SVT ideally will have a very narrow QRS complex. So there is narrow QRS, absence of P wave, and others like T wave is normal. We can see the ST wave is also good. Once we have a good idea, we already know from here that this is SVT. Why? Because in SVT, we know that the heart rate will be elevated more than 100. In this patient, that's 300. Then we know that it will be regular rhythm. So rhythm is regular. That means RR interval is equally placed. And then there is no P wave. That's the main thing. And the QRS will be a bit narrow. So that's the main finding of SVT. Quickly, you should also check the others like V1 to V6 for any other issues. So check for any ST elevation in anywhere. So there is no other problem in anywhere else. Okay, so then you can just talk about this bit. That will be enough for exam. You don't need to worry about these ones anymore. So that's the quickest way to read the ECG because we always look at the question. Question is about palpitation. For a palpitation case, our main focus will be on this big one or the lead two. Okay. So how we are going to explain this ECG to the examiner? So you will say, dear examiner, I would like to describe the 12 lead ECG of my patient John, who presented with a sudden onset palpitation and giddiness. The ECG shows heart rate, basically it is 300, heart rate 300 beat per minute, regular in rhythm, absence of P wave, narrow QRS complex, no ST change, T wave is normal, and QT is normal as well. So that's how basically we will explain the ECG to examiner. We already discussed this in our first cluster, which was chest pain, but right now you already know how to explain, right? Any questions with the ECG for SVT? Did you guys actually get it? The heart rate. So heart rate, have a look in here. So find out the RR interval. So in here, the RR interval, how many large square is there? One large square and maximum two small square, right? D? So to check the heart rate, we do this formula. So we divide 300 divided by number of large square in between two RR interval. So in here we know 300 divided by only one largest square. Now, because they don't need you to calculate the exact heart rate, even if you say almost 300, it will be enough. But basically, I would say a bit less because there is two more smaller squares. So between 270 to 280 will be the heart rate. So if you say 280, that's okay. If you say almost 300, that's also okay for exam. Okay, clear? So after we have done this, how we are going to explain SVT to the patient. So you'll say, John, thank you so much for waiting. From history, physical exam, and the ECG, most likely you have a condition called supraventricular tachycardia. Let me explain this in detail. So you draw a picture, same picture as we always do. So this is your heart, John, and the electrical impulse, or you can say our heart has electrical impulse, and this electrical impulse originates from here, and then it goes all over the heart to pump the blood to our body. That's why I have organized an ECG to check this electrical impulse. This was done when the nurse put those leads on your chest. In your case, there are some abnormal electrical impulse originating from the upper part of your heart, causing your heart to beat faster than normal. That's why you are having racing of your heart. And as your heart is not getting enough time to fill in, your brain is not getting enough blood, causing this lightheadedness that you are having. Are you with me so far? That's a very good explanation. A lot of people, a lot of course will ask you to describe the ECG in detail. A lot of medical students, even doctors, have difficulty to understand ECG. So what will happen to a patient who doesn't have any idea? So we really don't need to explain the ECG to the patient like this is P wave, that's QRS. No need. You just make it easy for the patient, and there is nothing easier than this explanation. So there are some abnormal electrical impulse originating from the upper part of your heart, causing your heart to beat faster than normal. And that's why you are having this racing of the heart. As your heart is not getting enough time to fill in, your brain is not getting enough blood, which is causing the lightheadedness that you are having. Okay. Now you can say that it could be due to other causes as well. So give some differential, like it could be a structural heart disease, it could be valvular abnormalities, could be ischemic heart disease, but you haven't got any chest pain. So you just give some differential diagnosis and say why it is unlikely. As part of the treatment, I will need to admit you to the hospital, call my senior, and also a heart specialist will come and review you. In the meantime, I will also take some blood for necessary investigations such as full blood count, inflammatory marker to rule out any inflammation, liver and kidney function, blood sugar level, cardiac troponin only if patient has chest pain, and thyroid function. We know that hyperthyroidism can cause SVT, that's why we're checking it. Troponin is not needed if patient doesn't have chest pain. ECG is very important, which we have done already. And blood count inflammatory marker, that's to rule out any infection or inflammation. And blood sugar to rule out any blood sugar issues. As your vitals are stable, likely the specialist will first try the vagal nerve stimulation. So remember one thing, that SVT treatment depends on the patient's vitals. If a patient is stable, the treatment is a bit different. If it is an unstable patient, the treatment will be shocking the patient, which is DC cardioversion. They don't give unstable SVT in the exam. So we will get a stable SVT anyway. So a stable SVT start with vagal nerve stimulation. So that's what we are talking here. So as your vitals are stable, most likely a specialist will try the vagal nerve stimulation, which is a nerve just on your neck. So you can show the vagal nerve. Commonly done by modified Valsalva maneuver. To perform this maneuver, we will ask you to blow into a 10 ml syringe hard enough to move the plunger. So you know the plunger in the syringe. So we will ask the patient to blow into a 10 ml syringe so that they can move the plunger upwards. So when they blow up the syringe and try to move the plunger, that's the time Valsalva maneuver will be activated. So then we will lay you flat, lift your leg up for 15 seconds. After that, we will return you to the resting position for about 45 seconds. So that's called modified Valsalva maneuver. If you have time, please explain this because it will show that you really know the updated guideline. Previously, people used to do carotid sinus massage. That's no longer the case. We don't allow carotid sinus massage because it sometimes causes more problem. Sometimes people do it so hard that they even dislodge some clot from the carotid artery and ended up causing a stroke. So nowadays, the best way to do the vagal nerve stimulation is this modified Valsalva, where we will ask the patient to blow into a 10 ml syringe to move the plunger, and then we just lay the patient flat and lift up the leg, and then we reposition the patient to the resting position. If this breathing technique does not work, then a specialist might give you a medication called adenosine through your vein to slow down your heart. It can be given up to 3 times with higher dose each time if needed. If the adenosine does not work, then a specialist will try another medication that's called verapamil to bring the heart back to normal. That's the calcium channel blocker. Other option can be IV metoprolol, which is a beta blocker. So we just mention the name of this medication as part of the treatment. If your heart still does not return to normal, a specialist might use a treatment called cardioversion. This is a quick procedure where a small controlled electric shock is given to the chest to help your heart reset to a normal rhythm. It is done under sedation, so you will be relaxed and won't feel any pain. But most of the time, usually the heart rate can bring back to normal with the initial step anyway. Okay, so then lastly finish with reassurance. Say that, John, I understand it is quite scary for you, but please know that you are in safe hands, and we will do everything possible to make sure you feel better and make sure that you can go home as early as possible. I'll give you some reading materials about this condition, and we will start all the treatment as I have discussed. Do you have any question? So that's going to be your SVT treatment. Any questions, guys?
Sir, is it necessary to explain about the carotid masses?
No, no need. So that's the main explanation that we have taken from the guidelines, from therapeutic guidelines, so and also a bit from John Murtagh. So you can see if vagal stimulation fails, we give IV adenosine, start with a 6 milligram, then 12 milligram, then 18 milligram if needed. And the second line option for adenosine is verapamil or metoprolol. Do not give adenosine in a patient who has uncontrolled asthma because that can cause bronchoconstriction. Okay, that's basically all the treatment that you need to mention if SVT comes in exam. Clear? No, usually what happens, Pranasa, that all these tasks will not be given in the exam. Most of the time when ECG is there, then they don't ask the treatment. That's what I have seen. So usually history, physical exam from examiner, investigation from examiner, which is the ECG, and then give diagnosis and differential. They usually don't give the treatment. If they give you the treatment, then sometimes they will not ask you to do the physical exam. So they know that it is impossible to do all of this in 8 minutes. But you need to learn because you never know what kind of task will be there. Yeah. So if patient is having unstable asthma, instead of adenosine or metoprolol, you will choose the verapamil. Yes, Neela? No, we don't need to talk about the doses of medication in the exam. The only thing that you need to say is the name of the medication. That's enough. No need of any dose. Okay, moving on to the second case, which is atrial fibrillation. So a 50-year-old lady coming to the emergency with sudden onset palpitation, history PFE, investigation from examiner and explain to examiner. The fourth task is a bit tricky. Explain the causes and complications of the condition to the patient. All right. So explain the cause and complication of the condition to the patient. That's there. So in this case, the history is going to be the same. The only thing that you might find positive is patient has hypertension. So hypertension can be a cause of atrial fibrillation as well. So because your task is to find out the cause, you need to find out the cause as well. So your history, physical exam, everything is same like the cluster. Then this is the ECG. So again, we are going to check the long lead, which is lead 2. In the lead 2, first we check, is this regular or irregular? Definitely irregular, right? So that means in here, we will not be able to find out the heart rate. It is possible, but it's going to take a long time to, to calculate the heart rate in an irregular rhythm patient. So do not bother because you will just end up wasting a lot of time. So you will just say that heart rate is increased because even by looking at it, you can understand that definitely heart rate is increased. Heart rate is increased, and then you will say the rhythm is irregular. Now we look at the P wave. Atrial fibrillation is a condition where the P wave will be absent and it will be replaced by some fibrillatory wave, right? So you can see here, these are the fibrillatory wave that we can see. So there is no P wave basically here that we can find out. So sometimes you might get a bit confused to see one, like maybe one P wave you can see, but don't get confused just because of that. Look at these long gaps one. In here, you can see that there is no P wave. In here, there is no P wave, okay? So when there is no P wave, or the P wave has been replaced by some fibrillatory wave, the rhythm is irregular. It is more than enough to think that it is AF, means atrial fibrillation. Okay, so P wave is absent and replaced by some fibrillatory wave. QRS, QRS is normal, you can say in here. It's not like very bad. You can either say it's a narrow QRS or you can say it's normal QRS. Okay, but definitely it's not wide QRS. So given it is at least one small square. Even if we say it's a normal QRS complex, it's fine. So QRS normal, we can see the ST is also in the isoelectric line, so no ST wave changes. And the T wave is normal. And check the QT if the QT is normal as well. So we can see that this is the Q, that's the T. So we know QT interval is between 8 to 11 small square. So this one has got only 5, 6, 7, 8. So it's basically normal QT. So we discussed about prolonged QT syndrome in our last class. That's why I'm just being a bit quick. So in the ECG explanation, you will explain. So in here, I've written heart rate 130, but you can just say heart rate is elevated, irregular in rhythm, absence of P wave replaced by fibrillatory wave, narrow QRS, no ST change, T normal, QT normal. All right. Our next task is to explain this to the patient. Did you guys get the ECG of atrial fibrillation? Are you comfortable that you will be able to read that ECG in exam? Yeah? Okay, good. So you'll explain to the patient. So from history, physical exam, and ECG, most likely you have a condition called atrial fibrillation. Let me explain in detail. So same, you will draw a picture and say the same thing. This is your heart, and it has electrical impulse which originate from here, and then it goes all over the heart to pump the blood to your body. That's why we have performed an ECG to assess your heart electrical activity. This was done when the nurse placed the lids on your chest. So see that I kept the same explanation. In your case, abnormal electrical signals are coming from the upper part of your heart, causing it to beat rapidly and irregularly. So that's the only thing I have added. That's why you are having racing of your heart. And as your heart is not getting enough time to fill in, your brain is not getting enough blood, and that's causing the lightheadedness that you are having. Everything is same. It's just this condition not only just beat the heart rapidly, but also irregularly or in a chaotic rhythm. That's the only thing we have added on the top of the SVT explanation. See that it's making things easy, and it means that you are smart enough to do these kind of things. Otherwise, you will just need to memorize a lot of explanation. Your second task was cause of AF. So you will say that it can be due to a lot of causes, such as high blood pressure, because I found your blood pressure is a bit high. That might be the cause. Sometimes it can be due to coronary artery disease, which is blockage of your heart blood pipes. But in your case, you haven't got a chest pain, so it is unlikely. Could be abnormal heart valves. So valves are kind of a door that allow the blood to move into the heart different chambers. But in that case, during the examination, I would get some abnormal sound when I was checking your heart. But in your case, you did not have that. Could be heart failure when heart cannot pump enough blood to your body, but you haven't got any symptoms of it, such as shortness of breath or any swelling of your leg or ankle. Could be a heart defect that you are born with, but you already said you don't have it. Could be an overactive thyroid gland, but again, you don't have any change in weather preference. You haven't been losing body weight or having any abnormal bowel habit. Could be sometimes excess tea, coffee, or alcohol. Could be due to lung condition, previous heart surgery. Sometimes even a viral infection can cause that. And there are cases where we don't even know why that happened, which we call idiopathic or lone atrial fibrillation. But based on the history that you have provided, I believe it could be related to high blood pressure that you are having. John, these conditions sometimes can cause complication, such as the chaotic rhythm that it causes. It can end up causing the blood to pull in your heart upper chamber, and it can cause clot formation. If a blood clot forms, it can dislodge from your heart and travel to your brain. If it goes to your brain and it blocks the blood flow of the brain, it will cause a condition called a stroke. Sometimes atrial fibrillation left untreated can cause weakening of your heart, leading to heart failure, where your heart will not be able to pump enough blood to meet your body's needs. Now, you just talked about very two scary complications. Say something reassuring here. Say, John, please don't get scared. These are complications if we could not control your heart rate or if it was left untreated for a long time. But in your case, you are here with us, and with proper treatment, this should not happen. Now, ideally, this will be the finishing of this case, but there are cases where atrial fibrillation treatment also very important. So it comes in exam. So you should know the treatment of AF. In the same way, we have discussed the AF is if we get an AF patient, we first look at whether the patient is stable or unstable. Unstable AF means blood pressure is less than 90/60. Patient is confused or patient is unconscious. Patient has severe chest pain or shortness of breath. That's unstable patient. In that case, we will need to go for DC cardioversion. But again, in exam, you get a stable AF. So let's talk about the management. So as part of the treatment, I will admit you to the hospital, discuss this with my senior, and also a heart specialist will come and review you. In the meantime, I'm going to arrange some blood tests. So I'll do the blood test to check your blood count, inflammatory marker, liver, kidney functions, blood sugar, same troponin if chest pain, thyroid function, and a scan of the heart known as echocardiogram. Since atrial fibrillation increases the risk of a stroke by allowing the blood clot to form in your heart, the specialist will consider starting you on a blood thinner such as apixaban or rivaroxaban after assessing your stroke risk. Very important when we talk about management of AF, we need to know whether this patient requires a anticoagulation. So that depends on the Chats-Vasquez score. The Chats-Vasquez score, you should know it by heart. So C for heart failure, 1 point. H, hypertension for 1 point. A, 2. So if the patient is more than 75, gets 2 point. Diabetes, 1 point. Previous stroke, TIA, thromboembolism like PE, 2 point. Any vascular disease like patient has peripheral vascular disease, 1 point. Age 65 to 74, 1 point. And if it is female, they get 1 point. Now, in this Chats-Vasquez score, a male with a Chats-Vasquez score of 0 and a female with a score of 1, they don't need any anticoagulant. So male with a score of 0, female with a score of 1 will not need any anticoagulant. Anything else, like male with even a score 1, like this patient had hypertension, right? At least 1 point. That is enough for us to start this patient on an anticoagulant. If it is a female patient, they need at least more than 1. So they need at least 2 points. So you will say, given that you are female and also have high blood pressure, your score is 2, which places you in the moderate risk category, meeting the criteria for blood thinner. Okay? So you'll need to say this. So you'll say that since AF causes risk of stroke by allowing the blood clot to form, specialist will consider starting you on a blood thinner such as apixaban or rivaroxaban after assessing your stroke risk. Given that you are female and high blood pressure, your score is 2, which meets the criteria for you to have a blood thinner. The specialist will then try to reduce your heart rate with a rate lowering medication such as metoprolol or verapamil. If that is not effective, a specialist might try an antiarrhythmic medication to control the heart rhythm, such as flecainide or amiodarone, based on your heart function to bring your heart rhythm back to normal. And even after that, we can't bring your heart rate or rhythm under control, then a specialist might go for a procedure called cardioversion. So cardioversion, the same thing as we discussed already, you need to explain here. So you can see here that beta blockers that we use for rate control of AF is atenolol or metoprolol. If we are going to check for calcium channel blocker, we will use diltiazem or verapamil. So the general principle for atrial fibrillation patient is we use rhythm control to restore the sinus rhythm. Especially rhythm control medication can be used if patient has been recently diagnosed, remains symptomatic despite you control the rate, and patient has reduced ejection fraction. So in these cases, we can use the rhythm control medication. So one patient has been recently diagnosed, patient is symptomatic despite putting the patient on a beta blocker or a rate control therapy, and patient has ejection fraction lower than normal. Electrical cardioversion. So electrical cardioversion is done as a last resort. Rate control did not work, rhythm control did not work. The third option is electrical cardioversion. Stable patient, definitely. Now, electrical cardioversion has the inherent risk that it can cause thromboembolism, such as a stroke by itself. That's why to reduce that risk, immediately start anticoagulant therapy in patient who is not on anticoagulation. So if we need to go for electric cardioversion, then we need to put the patient on an anticoagulant. If AF has persisted for less than 48 hours, electrical cardioversion can be performed without delay. If AF has persisted longer than 48 hours, then cardioversion should be deferred until it's been 3 weeks of anticoagulation. Okay, that's the management. You really don't need to know this much for exam, but for your real life experience, that's what we normally would do. So if AF is less than 48 hours and we need to go for cardioversion, we can do it without any problem. But more than 48 hours, chances that the clot has already been formed. That's why we need to at least wait for 3 weeks, put the patient on the anticoagulant, and then do the cardioversion. Okay? So that's all about atrial fibrillation management, guys. Any questions so far? So for AF management, same thing, you need to talk about anticoagulant, you need to talk about heart rate control medication and rhythm control medication.
Dr. Arshan, do we get the atrial fibrillation case in the GP clinic setup?
We can get it, yes.
Or then the management will be the transfer the patient by the ambulance.
Yes, so you'll need to then call an ambulance and transfer the patient to the hospital.
Okay, thank you.
Thank you. Any questions, anyone, about AF? Okay, so that's the only cases that we normally discuss under palpitation cluster. Okay, so I'm going to take a 5-minute break now, and then after 5-minute break, we're going to start the another cluster, which is hypertension. Okay, so let's take a 5-minute break and we'll be back soon. Thank you. All right, guys, let's start again. So you guys have some questions. Let's go through that first. So should we know who can give certain medication? Like in the case the specialist will give blood thinners? Yes, we should know that. We should not say in the exam that we are going to do everything as a junior doctor. Okay, so as part of junior doctor, we always involve our senior, so the registrar or SMO, the senior medical officer or the consultant. And also in this case, cardiologist will take over. Okay. And then an exam doesn't like that if you say that I'm going to do everything. Okay. Beta blocker given by cardiologist. Ideally, this will be fully managed by cardiologist. Sometimes if you are a bit more experienced junior doctor, you can do a lot of this. But as part of the exam, you are a junior doctor and you'll always say that a specialist is going to do this. As a GP, yes, we can start beta blocker. So sometimes if it is, let's say it's an atrial fibrillation and patient is stable, it can be treated in a GP setting sometimes if the GP is well trained to do so and confident to do so. But definitely if the heart rate is 150, 160, you will not treat that in a GP setting. Now for you as a junior medical doctor, as part of exam, you will not treat this in the GP setting. You will send that patient to the hospital. But in a real life, when you are a independent GP, you can treat a stable atrial fibrillation patient with a beta blocker. It can be done, but you have to be very confident and you have to make sure you review the patient and patient is well aware of when to go to the hospital. So it is complicated. That's why it's best that you send the patient to hospital and they will do the rest of the job. Yes, we can also give the anticoagulant. GP can do all of this. They can start anticoagulant, they can start beta blocker. GP will not start the antiarrhythmic medication. That will be definitely done by a specialist. Okay, starting with the new cluster, which is hypertension. Hypertension comes in exam a lot in different ways. And Rima, in explaining management plan to patient, what sentence should I use? What do you mean?
Sorry, doctor. I was thinking like if the main management will be managed by cardiologist, and I need to explain the management plan to the patient. In that case, actually, do I need to tell that? For your heart control, we need to give some medication, and for rhythm, we need to give that. So we can't use we will give that, right?
Yes, we don't use that. So as I already mentioned in that note, that first of all, in the exam, do not treat this patient in the GP setting, send the patient to hospital, and you will say that in the hospital, you will be seen by a cardiologist, and the cardiologist will do this.
Okay, I got it. Thank you.
Yeah. Magnesium sulfate is not needed as part of a treatment of AF. That's not usually even in the guideline at the moment. Okay, so we have got a patient with hypertension. 22-year-old female came in for blood donation. Nurse noted elevated BP 150/80 on 3 readings. Was advised to see the doctor. History from the patient, physical exam will be given on a card. So there are cases where you don't need to ask physical examination from examiner. They will provide a card and the card will have all the necessary physical exam finding. So after you finish the history, you just ask the examiner that, examiner, I would like to have the physical examination card, please. So then the examiner will give it to you. And then diagnosis and differential. Okay, so we've got a patient who came for blood donation and we found she has got elevated blood pressure. So we're dealing with a hypertension case. We know that 90 to 95% cases, there is no cause of hypertension, which is the primary hypertension or essential hypertension. Then there are some secondary causes as well, 5 to 10% cases, and we always need to rule them out. So we use the mnemonic track pads. So track pads has thyroid, so hyperthyroidism, R for renal artery stenosis, A for aorta, so coarctation of aorta, C for Cushing's disease or Cushing syndrome, K for other kidney problem like chronic kidney disease. We can also think of polycystic kidney disease here. Pheochromocytoma, that's P. A for aldosteronism, Conn's syndrome. D for drugs. There are lots of drugs which can cause hypertension like steroid, NSAID. Okay. Sleep apnea. So obstructive sleep apnea is a very important association, and stress. So when we take a history from a hypertension or from a patient who has been first time having elevated BP, we will need to rule this out. So we will need to rule out it's not thyroid, it's not renal artery stenosis, coarctation of aorta, it's not a Cushing disease, not a kidney issue, not a pheochromocytoma. We need to rule out aldosteronism and any drug, sleep apnea, or stress. Okay. So first of all, you will introduce with the patient. In this case, say that, hi Jenny, this is Dr. Arshan. I'm one of the doctor in this clinic. Very nice to meet you. Jenny, I really appreciate that you are here for blood donation. How are you feeling now? So patient will say, I feel all right. So Jenny, what happened today that when you came here for blood donation, our nurse checked your blood pressure, and we found that your blood pressure has been consistently high in all 3 readings. I'm a bit worried that why your blood pressure has been high like this. So I'm just going to ask you a few questions to find out more. Is that all right with you? Yes, doctor, it's fine. So Jenny, tell me a little bit more that has it ever happened before that have you ever been diagnosed with high blood pressure? No, doctor. Well, do you get any symptoms such as chest pain, shortness of breath, especially on exertion, any racing of your heart? Do you get any issue with your vision, any pain in your leg while walking? So we are just trying to find out whether patient already got some complication from untreated high blood pressure. So rule out any symptoms of ischemic heart disease, palpitation, which is racing of the heart. Sometimes hypertensive retinopathy can cause vision problem, and also peripheral vascular disease can be another complication from hypertension. Then we rule out secondary causes. So first start with the thyroid. So any recent change in your weather preference. Sometimes if patient don't understand what do you mean by weather preference, you can always say that do you feel excessively hot and sweaty even if it is very cold outside? So that's sometimes you can also ask. So do you feel excessively hot and sweaty even if it is very cold? Okay. Any change in your bowel habit or body weight? Have you noticed any lump on your neck? After thyroid, we have got all the kidney condition together. So renal artery, CKD, PCKD. So how is your water works? So water works is basically the urine. So how is your water works or urine? Any reduction of urine output? Any headache? Frequent leg cramps? Any swelling in your body? Any lump or bump on your tummy? Any family history of kidney condition? Every one of them has some reason why we're asking them. So for CKD patient, their water works, they might say that it has been reduced in amount. They also get headache, frequent leg cramps. They can have edema, so swelling of the body, especially facial or periorbital swelling. For patients with polycystic kidney disease, they can have a family history like that, or they can also start feeling some lump or bump on their tummy, especially around their flank. Okay, so that's that. Renal artery stenosis, there is no question for that because it's kind of a diagnosis by investigation. After kidney, we have got Cushing syndrome. So any change in your face, so they get moon faces, any muscle weakness or easy bruising. Or you can say, have you been gaining weight lately? So they gain weight a lot. They get moon faces, they get proximal muscle weakness and easy bruising. Okay, so that's for Cushing syndrome. Then for pheochromocytoma, any episodes of headache, sweating, flushing of the face. For obstructive sleep apnea, do you feel fatigued or tired in the morning even after having a good sleep at night? Anyone complained that you snore while sleeping? So patient with obstructive sleep apnea, they will have this snoring and they will feel very tired in the morning, even though they feel that they have a good sleep at night, but still they will feel very fatigued and tired in the morning. Ask about any stress at home or work. And if it is a female patient, then we ask the 5P. So the 5P, remember, we ask about their period. So when was your last menstrual period? Then we ask, are you sexually active? Because even pregnancy can be complicated with hypertension. So are you sexually active? If patients say yes, are you taking any contraception? So that's pill. We already asked about partner. So when is your last menstrual period? Are you sexually active? Is there any chance you can be pregnant? Any early morning nausea, vomiting, or breast soreness? Are you on any contraception, such as any pill? Okay. There is another P, which is for pap smear, which no longer we use as pap smear. We say cervical screening test. So cervical screening is needed after 25 years. This patient is 22-year-old, so we don't need to ask this. So just ask these 4 questions, and you'll find out this patient is sexually active and she is on oral contraceptive pill. Ask about SADMA, so smoking, alcohol, any regular medication, any social drugs. Ask about past medical and family history of any high blood pressure or any heart condition. Okay, so nice and easy. It's not very difficult, but definitely ask all these secondary causes. How we are going to explain this case? So you will say, thank you, Jenny, for all the information. From history and physical exam, most likely you have got hypertension, which is having an increased pressure in your blood vessels. Please do not get scared, as it's not an uncommon condition. Now, this is a case where I want you guys to say, don't just diagnose the patient as hypertension as of yet, because we know that to confirm diagnosis of hypertension, patient needs to have high blood pressure in multiple settings. Like, it's not just a single setting, we are checking multiple times, it's not the case. We have to bring this patient back again. Let's say at least patient should have multiple blood pressure reading high to confirm hypertension. So my suggestion in this kind of cases, although the exam is asking you about hypertension, my suggestion will be to say, from history and physical examination, Jenny, I have found you have high blood pressure on multiple readings, instead of saying you have got hypertension. And high blood pressure means your blood vessels are experiencing increased pressure than normal. Jenny, please do not get scared, because this is not uncommon. Most of the time, the reason why someone's blood pressure is going to be high, we can't find out the cause. But in your case, I'm suspecting it is due to the oral contraceptive pill that you are taking for the last few months. It could be due to other causes as well, such as someone can have a thyroid disorder, where the thyroid is a gland in our neck and it produces hormones which metabolize everything that we take. But in your case, you don't have any you don't have any change in your weather preference. You don't have any change in your body weight or bowel habits, so it's unlikely. So you just give all the necessary causes and say why it is unlikely. So given that you might have some other causes of high blood pressure, I would like to organize some basic blood tests for you, such as blood count, liver kidney functions, thyroid functions, blood sugar, and lipid profile. If everything comes normal, then we can be sure that it is just the oral contraceptive pill that is causing the high blood pressure. Left untreated, this can cause serious complications that can affect your heart, brain, kidney, even your eye vision. But you're too young and you do not have any other cardiac risk factor. So if we can manage you effectively, there should not have any complications. That's why my advice for you to stop the oral contraceptive pill, make another appointment with me, and we will discuss other alternative contraceptive option. In the meantime, please use a barrier method if you are intending to have sexual intercourse, such as condom. I also advise you to follow some lifestyle modifications, such as maintain ideal body weight, have healthy balanced diet, go for exercise at least half an hour, 5 days a week, and make sure that you don't stress, you don't end up having too much stress in your life. I'll give you some reading materials, and I would like to see you after the blood test is back. And in the meantime, when you come again, I will repeat your blood pressure to see how is the blood pressure after stopping the medication. Okay, so this is a case where it is a OCP-induced hypertension. Now, it's a tricky case in a way that I don't like to use the term hypertension. And that's why I mentioned at the end that I would also check your blood pressure when you come again. And I'll check whether the blood pressure has come down to normal after we stop the oral contraceptive pill. That will give the examiner an idea that I know that hypertension cannot be diagnosed just on a single day. It has to be multiple readings showing high blood pressure to confirm it. No, so you don't need to ask one particular symptoms multiple times. If you have asked nausea, vomiting once, that is enough to ask. You don't need to ask multiple times. It can be. So patient came for blood donation. She can be scared. And yes, the anxiety can just cause the high blood pressure. It can be. And if you want, you can also add that in your explanation that you can even ask sometimes here that, have you ever donated blood before? If patient has never donated blood and this is the first time, that can definitely increase her blood pressure as well. Okay? And to rule out anxiety, to rule out anxiety in this case that the anxiety of blood donation is causing the high blood pressure, you can also ask that were you feeling anxious for the blood donation? Patient will say in this case, no, I'm pretty good with that. I have donated blood multiple times, so I'm actually not worried about it. So that's also one of the things you can definitely ask in this case, that were you worried when you came for the blood donation, that you were quite anxious? Not a bad idea. White coat syndrome, it is not the possibility just yet. White coat hypertension is that when a patient comes to us multiple times, the blood pressure is high in the office setting, but when we ask the patient to check it at home, the blood pressure is good. That is white coat syndrome. But right now, still it is not the case because we don't know what her blood pressure looks like at home. Have a look in here. Diagnosis of hypertension should not be made on the basis of a single visit. Initial raised blood pressure should be confirmed on at least 2 other visits within a space of 3 months. And if all the 3 readings are more than 140/90, that is the time we can diagnose hypertension for a patient. Very important. So that's the John Murtagh hypertension diagnosis. So this patient has multiple reading high, but it's a single visit. So we can't just say you're hypertensive based on that. We can say that you have high blood pressure today. But to confirm if you have hypertension, we will need to measure your blood pressure 2 more times. And if we still find your blood pressure is more than 140/90 on those 2 visits, then we can confirm it. So that's why I advise everyone that do not say hypertension in here. You can always justify that most likely you have got high blood pressure. High blood pressure is usually what we call hypertension. But because this is the first time we have found it, and on a single visit, we cannot diagnose you to have hypertension just yet. We will need to confirm that by checking your blood pressure a few more times. Okay, so there are things that you can definitely mention in this case just to make sure that examiner understands that you have a very good basic on this. Okay. So therapeutic guideline says to confirm hypertension, the first reading is disregarded. The first one we will not take. And the automated clinic BP is determined by calculating the average of the second and third reading. All right, so the first one we will not take, and that visit, the blood pressure we will take is the average of second and third reading. Many patients have a home blood pressure machine, so sometimes we can also ask the patient to check it at home and tell us how the blood pressure looks like at home. If we say that yes, in clinic setting the blood pressure is high, and at home so we ask the patient to check the blood pressure for a week at home, and we can see that almost every day the blood pressure is high at home. That rules out possibility of a white coat syndrome, and that also confirms hypertension because this is multiple times we have found patients have high blood pressure. But not everyone we can ask that go and buy a $100 blood pressure machine. Some of them will not want to do that. That's why we can just ask the patient to come here. Like come to the clinic and we will check it. Once we confirm hypertension, the management of hypertension depends on Australian cardiovascular risk assessment chart. So many of you don't know how to manage hypertension as part of the guideline. And it's really important because exam ask hypertension management in different ways. So first, have a good basic about it so that any kind of questions come, you will be able to say something. So therapeutic guidelines say when to start blood pressure treatment. When a patient has established cardiovascular problem, like patient already is a known heart condition patient, or patient already have a peripheral vascular disease. So established coronary artery disease, that patient, if they are hypertensive, we will definitely start blood pressure treatment for them. And the best way to start treatment for a established cardiovascular patient, such as someone who had a stroke, someone who had a mini stroke, or even a ischemic heart disease, that patient, we will start them with usually ACE inhibitor or ARB. For patients at high risk, so how do we know who is high risk, who is intermediate risk, and who is low risk? So there is a risk assessment chart that we use in Australia that's called cardiovascular risk assessment chart. And you might have seen that during your MCQ preparation. In that chart, we will place patient's age, sex, if the patient is a smoker, what's the systolic blood pressure, what's the good and bad cholesterol ratio. So we put all of these in the chart, and the chart gives us whether a patient is low, moderate, or high risk. The low risk is someone who has got up to 0 to 5%. Moderate risk is up 5 to 10%, and anyone above 10% is high risk. So if we find out from the cardiovascular risk chart that patient is high risk, that patient will need to be treated with a blood pressure lowering therapy in addition to the lifestyle modification. So for a high risk patient, we don't ask, once you confirm hypertension, you don't just ask them to go for lifestyle modification. You also start them with treatment. For moderate risk patient, consider starting blood pressure lowering therapy in addition to lifestyle modification, but you can take the preference of the patient. If the patient prefers to wait for 3 months to try the lifestyle modification first, then we can do that. We can wait for 3 months, ask the patient to change their lifestyle and see if the blood pressure drops. If blood pressure drops, then it's good. If not, then we will start the treatment. For patient who is low risk, do not start the blood pressure treatment immediately. Continue the lifestyle modification even for 6 to 12 months before you consider treatment. Does it make sense, everyone? It's very important because you will never get a proper guideline about hypertension management, which is like very common. Lifestyle modification is vital. So when we talk about lifestyle, we say that do regular aerobic exercise such as walking, running, swimming, dancing, reduce alcohol, stop smoking, no added salt in the diet, healthy eating, and weight reduction in overweight patient. So these are the lifestyle advice we will talk to the patient. Sometimes if we want and patient want, we can involve exercise physiologist who can help the patient to understand necessary cardiac exercise. If patient is overweight and having trouble to lose weight, we can advise the patient to see a dietitian. So these things we can arrange for the patient. Now we are coming into the medication that we use to treat hypertension. All of you know about this, but still you will find out that you are not comfortable. So the medications commonly we use is either ACE inhibitor or ARB. Then we have calcium channel blocker, which is amlodipine or larcanadipine. And then we have diuretics, which is the thiazide diuretics. The choice of first-line antihypertensive is based on patients' comorbidities. So any of them can be first-line for the patient, but let's say someone who has a cardiac condition, ACE inhibitor or ARB should be our first choice. Okay? So it depends every time that which one we will start first. So these are the first-line treatment. There are some second-line antihypertensive. So if the first line does not work, we can go to the second line. So second line, we have potassium sparing diuretic, which is a spironolactone, beta blocker, alpha blocker, and sometimes even centrally acting alpha agonist. So we'll talk about that. Starting drug treatment. So when we start drug treatment for hypertension, we can choose either. We can start a single drug with a low dose, or we can use two drug, like a combination of two drug at a low dose. This two drug initially is usually reasonable who has high cardiovascular risk or a established cardiovascular problem. So most of the time in moderate risk patient, we will start as monotherapy with low to moderate dose. Okay, so start either a single drug with a low dose or combination of two drugs at a time. How to adjust blood pressure medication? So do not just keep on increasing or adding blood pressure medication every couple of days, because to have the optimal effect of the blood pressure medication, it takes at least 4 to 6 weeks. So to allow time for optimal effect of the initial treatment, changes to the drug therapy should be considered 4 to 6 weeks after starting the treatment. So you started one drug, wait for at least 4 to 6 weeks before you consider increasing the dose of that medication or adding a second one. Let's say for patient started on monotherapy, if the target blood pressure has not reached after 4 to 6 weeks, what's the target? Less than 140/90. Do not stop or change the initial drug, but add a low dose of a second drug from a different class. This is more effective than increasing the dose of the initial drug. What do I mean is, let's say I started a patient with perindopril, which is an ACE inhibitor. And let's say I just started patient with 2.5 milligram perindopril. And then after 4 to 6 weeks, blood pressure is still high. So what I'm going to do is, instead of increasing the perindopril to 5 milligram, I'm going to keep the perindopril 2.5 as it is, and I'm adding, let's say I'm just adding a thiazide diuretics. Okay, so what I have just done, I have added two different class medication to see if this works. And then again, I'm going to wait for 4 to 6 weeks to see how this two combination drug is doing. After 4 to 6 weeks, still blood pressure is high, then one by one, you will start increasing the dose of one of these medication until you go to the maximum dose of these two medication. So every 4 to 6 weeks, you can increase the dose of either one and go to the maximum dose and see if you can manage the blood pressure in that way. Is this clear, guys? If you have used maximum dose of two medication and still blood pressure is not controlled, that is the time we call it resistant hypertension. If it is a resistant hypertension, definitely try to rule out that whether patient is taking medication appropriately or if the patient is having some secondary cause of hypertension. So try to rule out the secondary causes in that case. So I was just saying that if let's say a patient has high cardiovascular risk or patient has moderate cardiovascular risk and patient has confirmed hypertension, and I want to start the patient with the antihypertensive. So I'm going to start the patient with a low dose of a single medication. Let's say I started with low dose perindopril, just 2.5, the lowest. Then wait for 4 to 6 weeks for the medication to work. You check the blood pressure, but blood pressure is still more than 140/90. Then instead of increasing the perindopril, you add another second class medication. So you add perindopril plus thiazide diuretics or perindopril plus calcium channel blocker. Okay? And every 4 to 6 weeks, you can increase the dose of any of this medication until blood pressure comes to normal. Make sense, everyone? Okay. So this is the basic management of hypertension. But there are patients who can have severely elevated blood pressure. And there is an exam questions which is about managing severely elevated blood pressure. So what is severely elevated blood pressure? So we have three different kind. One is severely elevated blood pressure without symptom. One is hypertensive urgency, and another is hypertensive emergency. Severely elevated blood pressure without symptom means that their blood pressure is more than 180 over 110, but they don't have any symptoms like no headache, no dizziness, no end organ damage. End organ damage means that patient will have hypertensive retinopathy, patient has nephropathy, so kidney has got involved, patient has peripheral vascular disease. So any of this, if it's there, we call it end organ damage. This is not an immediate threat to life, but we need to reduce the blood pressure between 1 to 2 days. So this patient can be treated in outpatient in a GP setting. We don't need to send this patient to hospital for treatment. So primary care treatment is fine. So this patient, we will start the patient with a treatment, like let's say we can start the patient with amlodipine, 5 milligram tablet, and then we will need to review the patient within 1 to 2 days. All right. So for severely elevated BP without any symptom, the treatment will be done in the outpatient or primary care with starting a single medication and then review the patient within 1 to 2 days. So you can see here, patient with severely elevated BP without symptom do not usually require immediate treatment and can be managed in the community. The steps in here is we need to, let's say that it's in the hospital. Let's say this patient came into the emergency. The first step is observe the patient. If patient was already on a blood pressure medication but forgot to take that medication, then we will give that regular drug and see if the blood pressure drops. So there might be like patient was given a medication before and patient stopped that medication for a week and blood pressure went super high. For that patient, we will just give that same medication and see if the blood pressure drops. But if the patient was not on any drug, we will add a new antihypertensive if blood pressure does not settle after a period of observation. So we will just observe the patient for like let's say half an hour, see if the BP settle down. And we will keep on measuring the blood pressure multiple times. But even after observation, blood pressure is still high, then we will start the patient with an antihypertensive medication and ask the patient to see his GP next day. Okay, so that's the treatment for severely elevated BP without any symptom. Yes, Pronuncio, you are right. So severely elevated BP will need multiple checks. That's the observation time when we will do that. Next is hypertensive urgency. Hypertensive urgency, their blood pressure is high, above 180 by 110, but they have symptoms, but they don't have end organ damage. Okay? This patient needs to be treated in the emergency department and the blood pressure needs to come down within hours. But treatment still can be done with oral medication. So for hypertensive urgency, we already know that blood pressure is high associated with symptoms, but no end organ damage. So this patient, if it is in a GP setting, we need to send the patient to hospital where hospital will do some investigation, so check some blood, do ECG and all to exclude any end organ damage. To check the end organ damage, they need to check the kidney function. They need to do a fundoscopy to rule out retinopathy. So they will do all of them, ECG to rule out ischemic heart disease. So they will do all of this to make sure this is not a end organ damage case. So once they rule out it's not end organ damage, then they can confirm that it is hypertensive urgency. For that patient, the treatment will be like this. If patient was already on a medication, we will just try that medication. If the patient was never on a medication, did not miss any regular medication, then we will start the patient with a oral amlodipine, 5 milligram, and monitor the patient over the next 6 to 24 hours. We'll see that if with a single amlodipine, if the blood pressure is dropping down. So just to recapitulate, for patient who has hypertensive urgency, they have elevated blood pressure but has symptoms, but no end organ damage. This patient will be treated in the emergency. So if patient was already on a medication, we will try that. If the patient was not on any medication, we will try a amlodipine and gradually observe the patient over the next 6 to 24 hours. Okay? Hypertensive emergency, that's the worst one. Their blood pressure is super high, more than 220 over 140. They have symptoms, they have end organ damage. This patient has an immediate threat to life. Blood pressure needs to be dropped within minutes. Sometimes this will be even admitted in the ICU. But we don't drop the blood pressure too fast. Every 2 hours, we drop it by 25%. We don't do a sudden drop, but the blood pressure needs to be reduced quickly. For hypertensive emergency, that patient usually need a IV medication, so IV hydralazine, clonidine, or metoprolol. This is not going to come in your exam because it's not the part of junior doctor, but you should know what is hypertensive emergency. So that patient will be treated in the ICU or CCU. All right, do you guys now understand the difference between hypertensive emergency, first severely elevated blood pressure without symptom, hypertensive urgency, and hypertensive emergency. And these are end organ damage. So pulmonary edema, that's why we do a chest X-ray, adrenal crisis, hypertensive retinopathy, nephropathy, and stroke. So there was a case, we don't know the case, but we know that there was a case about managing the high blood pressure, and especially the blood pressure was very high. So you need to have a proper idea to even talk about this management. Now that you have the basic, you can easily talk about the management that this patient will need. Okay? Everyone clear about the hypertension and the complicated hypertension management? Then the next case is antihypertensive non-compliance. So this is another case where patient is a 45-year-old patient, came to you for vaccination, but nurse got her blood pressure very high. She was given candesartan previously. Nurse advised the patient to talk to you. She recently moved to your place. Take history for 4 minutes and counsel the patient. So this is a patient who was previously been given a blood pressure medication, but she has stopped it. Okay, and now you found that her blood pressure is quite high. Very classic scenario. That's one question. There is another question which also frequently comes in exam. That's also a antihypertension non-compliance. Like this, you are a GP, a patient who was diagnosed with hypertension a year ago came in for follow-up. She is non-compliant on her medication. She has been drinking 6 standard drink daily for 5 years. Your colleague did a MMSE, which is the mini mental status exam, found out that the patient has short-term memory loss, but long-term is intact. Take history from the patient, counsel the patient about the general and specific measure to enhance antihypertensive compliance. This case we discuss in MMSE case, which is a psychiatric case. The case 1 is patient stopped the medication on her own because she did not have time due to moving places. She's stressed with family life and she's going through a phase. Whereas case 2 is the elderly patient who stopped because she keeps forgetting to take the medication. So it's a bit different, but the essence of the case is same, antihypertensive non-compliance. So how we are going to take history for this patient, the case 1. So first we introduce with the patient and say that, Jenny, I understand you are new to this place. How are you feeling? Are you feeling good here? Is this all right? Patient will say yes. Jenny, I really appreciate that you came for the vaccination. Are you having any pain in the injection site, or did you have any problem with that? So just start building a rapport first. And then you start asking question, well, Jane, the nurse has found that your blood pressure is on the higher side. Can I ask a few questions related to that? Then patient will say yes. Well, Jane, I found that you were previously prescribed candesartan, a blood pressure medication. Have you been taking the medication? Patient will say no. So how long you are not taking it? Patient will say for 3 months. Well, so when did you get diagnosed? How did you get diagnosed? Did you have any symptoms? May I ask why you are not taking the medication? So just find out a bit more about what's really happened. Then we go to the cause of non-compliance. A patient might not take a medication due to 3 factors. 1, patient doesn't like the medication, or the doctor who diagnosed the condition did not explain why the medication is really needed, or patient has their own belief. So first, did you stop the medication because you got some side effect from it? Did you have any issue with the cost or understanding of the prescription? Did your doctor advise why the medication is important to take? What is your view about the condition and the medication? So there are patients who doesn't like pharmacological treatment. A lot of Australian likes natural treatment, herbal products and all. So we need to know what's her view about this. Do you think the drug is beneficial? And are you trying any alternative treatment? So that's our, first we find out why she's not taking it, and then we find out whether she already got any complication from hypertension. So do you get chest pain, shortness of breath, or palpitation? Any swelling of your ankle or feet? Any blurry vision? Any blood in the urine, or any reduced urination for kidney disease? We find out what's her lifestyle looks like. So do you take healthy balanced diet? Do you smoke alcohol? Do you exercise regularly? Find out if she is under any kind of stress. So how is your home situation? Who do you live with at home? Any stress? Do you do work? How is work? Any other past medical history? Any family history of any heart condition? Okay, so that's going to be your history for this patient. So first find out why she is not taking it. Rule out all these 3 causes of non-compliance. Assess if she has already got any problem for not taking the medication. And lastly, finish with SADMA, lifestyle, past medical and family history. So you'll explain in here that thanks Jane for all the information. As you already know, you have high blood pressure or hypertension, which means your blood is pushing too hard against your blood pipes. Imagine your heart is a pump and your blood vessels, so you can say, imagine this heart is a pump and your blood vessels are like garden hose. If the pump pushes too hard for too long, it can damage the hoses. That's exactly what happens in hypertension. Your heart works hard. Over time, it can cause problems like heart disease, stroke, kidney damage, and many more. You usually will not get any symptoms until it becomes really bad. That's why we call it silent killer. But left untreated, you will start to get the symptoms like chest pain, shortness of breath, blurry vision, and increasingly tired. For this reason, it's very important that you take the medication even if you don't have any symptom. First, I would like to assess your risk of having a cardiovascular event, that is a stroke or heart attack, by using a cardiovascular risk assessment chart. For that, I will also need to know your cholesterol level. So I'm going to arrange a healthy heart check for you that will include a baseline ECG here and some blood tests to check your blood count, liver kidney functions, blood sugar, and fasting cholesterol level. But roughly, you have moderate risk based on your age, your blood pressure, sedentary lifestyle. So please start taking the medication, and based on other blood test results, I will decide whether we need to do further assessment of your heart, including a CT calcium score to check how much calcification or fat has accumulated in your heart blood vessels. Now, I know you are thinking in your head that what's all of this? So this is exactly how we treat this kind of patients. So first of all, to motivate the patient to take this medication, you need to say that why it is really important. Then you assess the patient's risk by using the cardiovascular chart. But for cardiovascular chart, you need to have some basic blood tests, blood sugar, kidney function, cholesterol, okay? Have a baseline ECG also. So, but even by looking at the patient, that if patient is age is a bit above 50, patient is hypertensive, sedentary lifestyle, or under a lot of stress, they're already in a moderate risk. So for them, usually we advise to continue the medication, but based on the further assessment, if the assessment shows patient has a high risk, in that case, you can also send the patient for a CT calcium score where we can find out how much calcification they have already got in their heart. Along with the medication, please adopt a healthy balanced diet, regular exercise, cut down any added salt and alcohol. I am relieved that you do not smoke because smoking can cause more issues. I understand that moving to a new place is quite stressful, so please take your time and gradually get adjusted. You can try some relaxation techniques such as mindfulness, yoga, meditation. Please document your blood pressure in a diary for a week at home and show me so that I can see how is your home blood pressure. Here is a reading material for further insight. I will see you in a week time with blood pressure diary and the other test result. Okay, clear guys? So it's a very nice and easy explanation, but you need to explain in this way. Any questions? The second case that we have with forgetfulness, I will discuss that in our psychiatry case, but you can definitely give it a read from the note. The last case for tonight is ambulatory blood pressure monitoring case. This case is important and it's all about just explaining things. So ambulatory blood pressure reading is kind of like a 24-hour blood pressure monitoring device. So 45-year-old male presented in a GP practice to discuss his blood pressure reading. He presented last time in your clinic a few days back and you checked his blood pressure, which was 154/92. You asked him to check his BP at home and he came with this reading. The average is between 120/80 to 150/80. You also did a fundoscopy which found grade 1 retinopathy. So you can see there is a marked discrepancy between the blood pressure. So you can't diagnose whether he is hypertensive or not, because sometimes it is good, sometimes it's high. When there is a marked discrepancy between multiple blood pressure readings, that is the time the ambulatory blood pressure monitoring comes into play. So you will explain the patient what is this ambulatory blood pressure, explain the implication of high blood pressure, and what investigation you would like to order for this patient. So you will greet the patient, same as we do, appreciate the patient for bringing the home blood pressure reading. And then you explain the patient that, well, thank you so much for bringing this 1 week home blood pressure. And as we can see from this home blood pressure reading, that your average blood pressure is staying between 120/80, which is quite normal, but also sometimes it's going towards 150/85, which is a bit higher than normal. Normal blood pressure should be below 140/90. So that's the time you will say, so because there is a marked discrepancy between multiple blood pressure reading, I would like to order a ambulatory blood pressure monitor for you to confirm whether you have got high blood pressure. Okay, so you can explain in here, ambulatory blood pressure monitor, it's a kind of a device that we are going to apply on your arm, and that device is nothing but a blood pressure device, which will check your blood pressure regularly over the next 24 hours. It will check blood pressure when you are working, when you are resting, or even when you are sleeping at night. And then it will give us an average blood pressure throughout the 24 hours. If that comes high, then we will confirm that you might have high blood pressure or hypertension. Now, we also want to rule out whether you have white coat hypertension, which means that clinic or hospital is a kind of place with a stressful environment. Sometimes it can cause release of certain chemicals in our body, which can increase the blood pressure, just during that moment. While in reality, your blood pressure might be completely normal when you are relaxed. That's what we call white coat hypertension. So we are going to make sure that you don't have this white coat hypertension, because it means that your blood pressure goes high in a clinic setting, but at home it is normal. So once you give that home blood pressure, once you give us that device, then we will check your blood pressure reading. And if ambulatory blood pressure confirms that yes, you have hypertension, then we will manage you accordingly. David, hypertension is a silent killer because it can sometimes cause severe damage inside your body without doing any symptoms. For example, it can affect your heart, causing enlargement of the heart. It can cause angina or even a heart attack. It can cause brain damage by causing bleeding inside your brain, known as a stroke. It can damage your kidneys and eyes. We can already see some early changes in the back of your eye. So it's very important to control your blood pressure at this stage so that we can prevent further damage. It can also cause decreased blood supply to your lower leg, causing pain during walking. Please do not get scared. You came very early, and with appropriate management, if we can control your blood pressure, we can avoid most of these complications. John, most of the time, there is no known cause of high blood pressure. In only 5 to 10% cases, there might be a cause. So to rule out any secondary causes and to assess your cardiovascular risk, I would like to add in some blood tests, such as full blood count, thyroid function, liver kidney function, your blood sugar, fasting cholesterol level, and an ECG. I'll also arrange a urine test to make sure you are not losing any protein or blood in the urine. Because if the patient has microalbuminuria, it means that they're losing protein in the urine, which will be an indication that it's already nephropathy. Once the above investigations are done, I will assess your risk of having a stroke or heart attack using a cardiovascular chart and then manage you accordingly. Given that we have already noticed some changes in your eye, you will be in moderate to high risk already. That's why if it is confirmed to be a hypertension, we will need to start a blood pressure lowering medication for you. I will also send you to an eye specialist for further assessment. Please do not get scared. With proper management of your blood pressure, we will be able to protect your eyes from further damage. Very important to reassure the patient. In the meantime, start lifestyle modifications, so explain those things and finish with 4R. Okay, so this case is not about any history, rather it's just asking, like explaining everything in detail one by one. Presence of retinopathy cannot confirm that it's a hypertension, because retinopathy can be due to a lot of other causes. They did not say it's hypertensive retinopathy. So yes, that is the most likely cause, but we can't confirm it yet without doing the ambulatory blood pressure. Okay, guys, so that's all the things that you need to go through for cardiology. Cardiology, as you can see, there is a lot of topics, lot of questions, but I hope that you guys understood the cluster-wise approach. I hope that you guys enjoyed the session. Do we start the treatment immediately? Not yet. We should wait until we do the ambulatory blood pressure. Okay, now this is your last session for the free 2 weeks class. I hope you enjoyed these sessions. Even if you're not going to join the course, I hope you learned few things that you can use in your exam. But for the course student, your orientation class is on Friday, so which is going to be 23rd. And we have already sent you all the necessary information to join the class. Please make sure to join the orientation session. And I'm sure you also got the full schedule for the next 1 month. Okay. Now we will finish here with just a bit of a discussion about the course so that you know about the course. If anyone have any questions regarding the course, please feel free to unmute and ask. So the clinical course that we are offering, it has everything someone needs to pass the exam if you know how to utilize the course. So throughout this couple of weeks, we took a lot of session for you to understand how we take the class. And you also learned our other mentors, you did role plays. So you have a pretty good idea if this is the right course for you or not. I want you to understand that clinical course, which is extensive like ours, you will not get a extensive 5 months course anywhere like this. And this is also the most affordable course, which is a accredited learning provider in Australia. So all of our mentors are Australian doctors currently, and most of them, like all of them, are above registers. So we are well oriented with the Australian health system. And please know that we will not give you anything which is not currently in the guideline of Australia. You might have already noticed that the notes that we are showing you, the discussion that we are having, we are always maintaining that guideline, maintaining the updated therapeutic guideline that we will follow here exactly. So that's what you need from a course. A course mentor should have that knowledge, should have that therapeutic knowledge so that you don't just learn something which is not even been in practice in Australia. On the top of that, the course also provide extensive role play sessions. The role play sessions are based on the exam related questions, which is high yield for exam. In your case, our focus will be mainly on 2026, but also you will get all of our last 3 years video recordings of all the role play classes that we have taken. that has enough cases that can come in any exam, because we have done so many cases and there will be no cases left if you can cover that. Also, we have notes of all the questions that we have solved till 2018. So there is a long list of questions that we have done. So if you can cover at least 1 year of these questions, you will be fine. You will be okay to go for the exam. The course also provide, so as we say that the course divided into theory-based cluster plus role play of important questions, which is high yield for the exam. We also offer physical examination classes. So if you think that how we are going to do a physical exam, which is face-to-face format online, I can assure you that it will be fine, because we have been doing this for a long, long time, and our students don't need to even do a face-to-face physical exam after we do this online 1 month physical exam. Okay? All I want you to do is to make sure that you practice it with someone, because you have to practice it after we show it to you. We also offer online mini mock exam, which is like just a few question exam, not a full mock exam, but that mini mock exam will be kind of an exam so that you keep well oriented with your study. You also get recordings of every class, which will stay for until the course is finished. So if you subscribe for 10 months, the entire 10 months, you will get the recording of every class that we have done. You will find out there are a lot of courses where they will not provide you this kind of recordings, and you will need to keep on subscribing their recorded version of the class, which is not even updated, and you will keep on just subscribing them because you keep on forgetting it. So it is not convenient for clinical exam preparation, because you really need these recordings. After a couple of months, everything that we have discussed, you will start to forget, and you need to come back and just, if you hear again quickly, all of these things will come back to you. And before exam, you will need to hear a few of the recordings, especially the important classes that we are taking. So please make sure that you know this before you join any courses, as part of your clinical preparation. You can claim 130 CPD points from our classes. We also offer course completion certificate, which you can use it for your CV or registration purpose. If you don't have 5 months time for your preparation, once you make full payment, you also get the full recording of the last batch that we just finished. So you can always go through that last batch theory classes, finish the full theory, and just start doing role play. That's also sometimes people will do. Classes, we take 3 days a week, 8:30 to 10:30 p.m. Sydney time. Okay, so these are the subscription option. You can go through them, and if you have any questions, you can always reach us. So you can research through the email. So this is the email that you can use, or we have a Facebook group where you can always see any update happened about the course. We always provide update in the Facebook group as well. If you want to register for the course, you need to click on this register now button, and then it will take you to the necessary steps. All right. So that's basically all about the course. If you have any questions, please feel free to ask. Bora, so our ex-student can join the recent recall class as well. So please send me a message in my messenger. We can send you the information about it. So the paid students have been added to our Facebook course group, Alex. So if you have made payment for the course and you haven't been added to our course group, the course group name is First Aid AMC Clinical Batch 14. So if you haven't been added to that batch, you will not get any any course related information because we usually update everything there. So please send me a message in my messenger. Still that you have already paid for the course, but you haven't been added there. Okay, then we will add you. Next class is on 23rd. You should check your email as well because I have sent email to all the students who has enrolled. We haven't planned or we haven't fixed any date for face-to-face workshop yet, but definitely it will be in Sydney and Melbourne. Yes, Justin, if you have registered today, you should be able to access the portal by Friday. Usually it takes 2 to 3 days, so hopefully it should be okay. So if any of you have made the payment, please send me a message because in here I'll not be able to remember all of your name. So please send me a message and make sure you send a Facebook friend request to me because I will need to make you friends to invite you to these groups. All right, guys, so that's it for tonight. I hope to see you all on 23rd. And I wish that if any of you are not our course student, I wish you all the best. And hopefully like I can see like many of you are the course students. So we will have a good journey ahead anyway. Okay? I'll see you soon. Thanks all. Have a good night.